Thanks everyone for being here. My name is Dennis Cleary and I'm joined today by Krista Covell-Pierson, and she's going to talk to us again about transitioning home after a rehabilitation stay. So thanks so much for joining us, Krista. Could you tell us a little bit about your background and your interest in this topic of having a positive discharge home?
Sure. So I am an occupational therapist and have been an OT for about 22 years. I started out in skilled nursing facilities, home care, hospitals, really traditional settings. And when I was first starting out in occupational therapy, I felt like when I was discharging my patients home, they would go home with home care and every need would be taken care of. And then once I got a little bit more experience under my belt, I realized that's not always the case, that there's a lot of things that patients still need help with and a lot of details that get missed sometimes
Hmm.
in a good discharge. So I started working with a neuropsychologist actually that really valued occupational therapy in the home. And that sort of grew into a private practice that I did on the side many times, but it really helped with good discharge planning to home because I ended up following a lot of my patients home. And
Hmm.
then I really was able to see what we can do better on the inpatient side and when we come in on the home care side to make that a better transition for the patient. So overall, it's just as a much better quality of an experience for a patient.
Great. And so you have your own company now. We'll talk about that a little bit later in the podcast. And I have a good friend of mine. So male OTs were a funny lot. We tend to move everywhere together. So he's one of my OT classmates, and we talk most days of the week actually. And so he's doing home health now, and occasionally he'll be between visits, and he'll just give me a call, and not disclosing any HIPAA information, but certainly these interesting situations that sometimes he finds himself in the home. So, can you talk a little bit about, like, do you think that occupational therapy practitioners might have some misunderstanding, especially those that are more, SNF or rehab based, about the reality that many of our patients go home to?
Yeah, I don't know if it's so much that OTs have like a misperception. I think there's just so much that happens when a patient goes home, and some of those things we can't anticipate, but I think we can open up our landscape a little bit, if you will, when we're looking at discharge and what does that really look like. We don't want to just look at showering, dressing, hygiene and grooming, those types of things, but really long term, what is going to be going on for this patient? Because most people are pretty motivated to do beyond that. So we
Hmm.
need to be planning for that, even if they're not ready. There's just a lot of details and conversations and IADL areas to address with patients that I think we miss. And some of that has to do with time too.
Hmm.
We only
Sure.
get so much time with our patients. And so, sure, we would love to cover all these things, but we feel really strapped for time a lot of the time.
Yeah, absolutely. So you did start your own company, so that's pretty exciting. Can you talk a little bit about how what you're doing is maybe different than a traditional home health company might be?
Yeah, we do what we call mobile outpatient services or community based treatments. It's a little bit more commonplace, but it's certainly not mainstream yet.
Hmm.
It was very new when I was doing it. I only knew a small handful of therapists, and now I know a lot more. But really, what it is especially as OTs, we value the environment that
Sure.
patients are moving around in so much, and it influences our treatments so very much that it's important that we're there in people's homes and at their jobs and on the city bus, and we can actually problem solve and do really context-based treatment, that is very impactful for the patient. So that's what we do that's a little bit different. So we do
Hmm.
physical, occupational speech therapy. We also have fitness trainers. For anybody that's ever worked in skilled nursing and worked with like restorative nursing,
Hmm.
that's why we brought in the fitness training piece to try to help support patients after they come off of therapy services. And we're a little bit more a la carte for patients. They can pick
Hmm.
and choose what services they want. We're not in there, as a group, like a home care stay, that kind of
Hmm.
thing. And then we can do maintenance therapy, which is a little bit different. And then we can come in and out as patients need or want us to. So there's a little more flexibility with us.
Gotcha. So how do you offer those a la carte services? Is there sort of a menu that people choose from? Is it just part of the occupational profile, and you're talking to them about different things you can offer. What's that negotiation, or how do you decide what goals, or how does the
Hmm.
and I guess, do you call it is it a patient? Is it a client? How do you refer to the folks that
Yeah.
you work with?
We actually call them patients. We tried
Uh-huh.
for a long time to transition it to client, but
Uh-huh.
because in the medical world everybody calls them patients, we just went back
Hmm.
to calling them patients to make it easier, mostly for doctors and things like that.
Gotcha.
As far as figuring out what a patient needs, usually we'll get a referral or a phone call or an inquiry, and somebody is being referred for a specific service.
Hmm.
So let's say, we want physical therapy and this is why. And then when the PT goes in, they might screen for other issues. Maybe they're having, problems with their ADLs and bring in OT. Other times physicians will just send over orders for everything. And then
Hmm.
we sit down with the patients once we do the eval, just really typical, standard practice that we run through all the issues that we're seeing. And then we talk about what a good treatment plan would look like and set it up from there. So it's just nice because, if a patient is feeling really overwhelmed because they have PT, OT, and speech coming in, and maybe they're going to an outpatient service for something else, we can say, okay, well, maybe PT is going to hang back for a while and they'll come in when OT is done. And we can be a little bit more creative and let the patients call the shots a little bit as long as they're safe and still making progress.
Great. So can you talk a little bit about, there's, OTs on both sides, the OT practitioners on, the inpatient side and then the home health side. Can you
Mhm.
talk a little bit about what an inpatient therapist could do to make the transition home a little bit more seamless?
Yeah, I have a few ideas actually. And one of those things really just starts with conversation and having
Hmm.
a little bit more in depth conversation and asking a lot more questions or hypothetical situations. For example, I had a patient that when he would pull into his garage, and then by the time he would get out of his garage and go to the door, he would have the door shut and then the light would be off above the garage, and he then would lose his balance because he couldn't see and it was dark. So sometimes I'll even use examples from other patients like that. So,
Hmm.
what would you do if you were in this situation? And then you get a better idea of maybe how prepared your patient is in emergency situations. Talking about other areas of the house or even times of year. So maybe if it's, getting closer to the holidays, where do you keep your holiday decorations? How are you going to
Hmm.
get them down? Just those conversations. And you can even have those conversations while you're walking down the hall or going, down to the rehab gym or to take
Hmm.
a shower. They can be sort of casual, but very helpful and give you
Hmm.
some good talking points. And then I also really like to do as close to a simulation as we possibly can. And that's tough sometimes because
Sure.
we're sitting in, places that are very accessible and bright and the lights are on and the hallways are clear. And so it's nice to go in and maybe you make a mess in your therapy kitchen and you have them clean it up or talk about what their kitchen looks like. Maybe they have a galley kitchen, maybe it's really big and open, but simulating as much as you possibly can at home. And that's going to increase the patient's confidence too to
Sure.
go back to their normal environment. I also like to share things about people that my patients can relate to. So if I have a patient going home and maybe has a new amputation, I can talk about a patient without giving, private information away, but to talk about what was successful or what was difficult. And that can help too, just to help that patient not feel so alone. And
Hmm.
then also getting them plugged into organizations that maybe they have similarities with. So, for example, in Northern Colorado, we have a really strong Parkinson's support group.
Hmm.
So if I'm on the inpatient side, make that call when you're there, or pop open the website on your device with your patient while they're taking a rest break so they feel a little bit more comfortable, just to start linking them back to the outside world, because when they're in an inpatient setting, it's really tough. And then that leads to, knowing your community resources, giving, names, phone numbers, helping them make those calls. And then also just doing things that are as close to real life as possible. If they
Hmm.
take their showers in the evening. That might be hard because you don't work in the evening, but maybe make that your last visit of the day and see how tired they are. When I worked in skilled nursing, we used to do a lot of meal prep for safety training and, everything that we do. We would also do frozen meals, and
Hmm.
we would make a meal. They would get to invite a couple other residents in that they wanted to eat with, or their family. And then we also had them make a double batch so that they could freeze it and take it home with them. So they
That's
have a
really
meal
smart.
there when they get
Hmm.
home, So it's just really being practical and thinking
Sure.
long term. Um, and it makes it more fun. And then it gets that patient to really start thinking a little bit more analytically about going home. And I always tell my patients that threshold is not magic. You're not going to be all better when you go
Hmm.
over that threshold. So we need to be prepared, and just really having those conversations is helpful. And then I feel like your patients trust you more too when
Sure.
you're being as realistic as possible about home.
Yeah, and I know there's an inpatient hospital that I'm pretty familiar with that actually moved some of their, that it seems like it used to be the last night before they would go home was the night they went to the apartment and then, had everything.
Hmm.
But when they found that there were issues on that last night, um, so they started to move it, so that it was earlier in the stay, so that
Hmm.
um, it just, as you said, real life, as the closer we can get to being authentic with the interventions that we're providing, I think the
Hmm.
more successful the therapy can be, and also I think you get a little bit better buy-in from the patients you're working with, because they can't just say, well, I'll do different at home, because if they've had to really do some of those things that they're going to be doing at home, it helps them take that a little bit, not more
Hmm.
seriously, but I think they and then their support folks can see that as really being a little bit more imperative. So what are
Yeah, and I
some
think
areas?
it
Oh, go
helps
ahead.
too. Oh, sorry. It helps too to run a little bit of interference with the nursing staff,
Hmm.
because they a lot of times have all these things they need to get done. And sometimes we just need to say, we want the patient to ask for their meds when they're due. We're having them watch it. It's not that we're saying if the patient doesn't call for their meds, don't give it to them, but
Right.
just to really educate the nursing staff too about the importance of backing off a little bit and letting the patients have more independence, and then not telling your nursing staff just to do that, but to have a good team conversation about the why behind that,
Right.
so that you guys are all working together towards the same goals.
Yeah, because I think of that, that's part of who we are, I think, as occupational therapists. But it's not how every profession is, and so
Hmm.
just I think the more we can help them see our way of living. No, I'm just teasing. But the more that
Yeah.
we get everybody on the same page, I think
Hmm.
it helps to improve outcomes.
Hmm.
So, what are some other areas that you think that occupational therapy practitioners can address during that inpatient time that sometimes you might see, or they may have missed as they're getting people ready to transition home?
Hmm. A few different things like getting the mail. There's a lot of times that's not brought up. Anything that has to do with IADL. So we sometimes we'll talk about, who's going to bring you your groceries? Well, who's going to put them away? And is that long term? So to really dive deep into those IADL needs. Also lighting, and if somebody has low vision, to make sure that we are addressing that in addition to, maybe they've had a hip replacement or whatever, but if they have low vision, get some education in there too about what's going to help with lighting and how to set things up at home, because it all is connected. And then also emergency planning is a
Hmm.
big one. So not just, do you have a life alert, but who's attached to the other side? And does somebody, if it's a family member, do they realize they're basically on call all the time? So what happens if their son is like, yeah, I'm the emergency contact, but let's say he travels a lot.
Hmm.
So then he's on an airplane and then that calls and it doesn't go to anybody. So those are the things that I feel like we have to start big and then look at those little details. And it's really what our skill set is too, because of
Hmm.
our training and activity analysis. And we really just have to get down into that. And when we're in an inpatient setting, it's so hard to dot all the I's and cross all the T's because everybody is so different. Um, And I think that running through a daily routine and really hour by hour, what are you doing and where are you doing it,
Mhm.
can be helpful on the inpatient side to talk about, and to pull some of those things together and even incorporate those things into your goals. So if they need
Mhm.
to get the mail, simulate that. And are they going to have a walker where their keys are and they're fumbling with their keys in the mailbox, or they have to walk down the long driveway to open it up. I mean, there's a lot of different things that contribute to things that we just don't talk about on the inpatient side.
Right. Yeah, I had a one of my former coworkers is an OT and has two sisters that are OT, and I think there's a psychologist and a nurse in the family, and their mom went into an inpatient stay, and um, mom said that there were 3 steps into the house, but she was in from Pittsburgh, so there were 3 steps at the top, but there were like 20
Oh,
steps to get to that 3 steps because they were getting ready to
hmm.
discharge, and the family said no, we're not discharging, and we're able to really show that mom was not quite ready to get up those 20 steps to get back into the house. So
Yeah. Yeah.
other things that you think might be uh, important in terms of thinking about for that occupational therapy practitioner as folks are getting
Hmm.
ready to go home.
Yeah, I think you bring up a great point, and knowing that sometimes we don't get exactly the information we think we're getting. So
Yeah.
I had a patient that said, I said, well, when you go in, do you use your front door? Yes, I do. Okay, how many stairs? 4 or 5? Well, come to find out, the stairs were rotten. The wood was rotten. So
Hmm.
they weren't safe. So he was actually using the back door, and that was a completely different setup, but he didn't
Hmm.
share that with me. And so sometimes things get lost in translation. But to your point too, with the stairs, if you have a family member that can bring in photographs, text them if they're comfortable with that, email it, make sure you're HIPAA compliant and all of that stuff, or videos, or if you can even
Hmm.
do a FaceTime call, there's free applications that can be HIPAA compliant. We do that quite often when we have
Hmm.
patients that live in the mountains and we can't get to them, but we want to see
Sure.
their house. And it's so helpful, just to say, oh my gosh, like, yeah, you've got a great setup there, but you've got all your cat litter is in the way, things like
Sure.
that people just don't talk about. So pictures, videos, super duper helpful to see that. And then one of the big things that I think is glossed over a lot or just altogether skipped is driving.
Hmm.
And if we know we're sending somebody home and they have been a driver, we really do need to address that. And we also know that driving is one of the most meaningful activities of daily living to most people. So people want to drive. And
Hmm.
even if they're not cleared to drive yet or anything like that, we have to have those conversations
Sure.
with patients for sure.
And it's hard sometimes to get physicians on board with that as well, because
Hmm.
they want their high ratings when people leave. Not that's not why they do it, although maybe.
Yeah.
So that they so it can be really difficult. I know actually one of the first patients that I dealt with or that I was treating after I graduated had some driving issues that I had to deal with, and it was sort of the rehab manager really saw it as my way of learning to be a therapist. That how do you negotiate
Hmm.
this with this individual and with the family and with the
Hmm.
Department of Transportation and all those sorts of fun things. So that was something I was perhaps not well prepared for when I was in
Yeah.
school, but it's an important part of what we're doing. And I obviously it's a huge loss when people stop driving. I know my dad, when we ended up he went through a driver rehab program, and they were the ones that made the decision that he shouldn't be
Hmm.
driving. And even to the last couple of weeks he was alive, he still said, my mom should not be driving. That there's no way that anyone could have passed the driver test that he was put through. So, but
Hmm.
obviously, just
Yep.
such a loss for people when that happens. So, other
Hmm.
ideas about transportation when driving isn't an option, or how do you connect people to resources around
Yeah,
that?
that's another really good conversation because um, giving up driving is very emotional. People can feel very vulnerable, very attacked. They don't want to burden, because you can, even if the daughter or the son or somebody says, well, I'll take you, mom, it's no big deal. They don't want to ask. And
Hmm.
sometimes you do just want to jump in the car by yourself and go. So again, it's having those conversations and then also really validating the emotional pieces that come with it. And it's also helpful if you can have that conversation maybe before somebody's having to give up driving. Like, what will you do if you do have to give up driving at some point? What are your options?
Hmm.
And then if you are talking about it and it's already happened that somebody isn't able to drive, it's really important that you have a good overview of what's available in your community, and everybody's
Sure.
community is so different.
Right.
We have some driving resources here, but they're not great. And so it's tough for me to recommend them sometimes with confidence because I know how frustrating it's going to be for the patient. But I can share that with them and talk about how to brainstorm around it and solve some of the things. We've also practiced with patients from, like, any sort of transit system that's door to door. We've done
Hmm.
Uber with patients, the bus, community volunteers, hiring a driver, anything like that. And sometimes there's really no great option. And so sometimes just processing that with your patient can really help.
Hmm.
And then once they start doing something differently, it's oftentimes not as awful as they feel like it's going to be, but sometimes it is. And they're pretty
Sure.
upset about it for a long time. So, but being able to go through all of that with a patient is important.
Yeah, that was my dad. Absolutely. He was a salesman, so he sold carpet was his thing. So he would go
Hmm.
around to different carpet stores and just drove throughout the state, and he loved doing that. And even
Hmm.
in retirement, still really appreciated driving. But one of his big activities is he would go and work at uh, a soup kitchen and help give make meals and that sort of stuff. And so some of the other guys that were in the soup kitchen, it started to become what they would do. My mom, I think, would drop them off, and then they would bring them over they'd go out to lunch, and then they would drop them. So it was trying to negotiate, what that can look like. But definitely,
Hmm.
I think took a toll on his mental health. He was still
Hmm.
always an optimistic guy, but I think definitely lost a sense of uh, of himself because obviously it was a very meaningful occupation as it is to me. So
Hmm.
hopefully when I get to that point, I will be less dramatic for my child than my father was for me. So
Yeah.
um,
The research says that, we're at an age now where most people will outlive their ability to drive. And
mhm,
that's sort of the first time in history that we're seeing that.
mhm,
So it will become more and more of a problem as people live longer. So these conversations are really good to have even now. And I challenge therapists, even in your own personal life, like, what would you do, even if it's just a temporary thing, if you could not drive for 30 days? And
right,
you think about your life, if you have kids or you have a job or you volunteer, like, what would you do? And resources come into play. And I think that can help drum up a little bit of empathy sometimes from the therapist, because
sure,
it's very easy when we're driving back and forth to work to not really think about how hard it really is to live in the United States and not drive.
right.
So unless you're like downtown New York City, it's pretty tough.
Yeah. Well, and even with some of the paratransit and other services that are available, the federal law is that the paratransit services should be, at the same level as the typical public transportation services. So if you're in an
Hmm.
area that doesn't have great public transportation, then chances are the paratransit services are not going to be that great either. So
Yeah, that's so true.
someday hopefully we'll continue to make some progress on public transportation so that it's a little
Hmm.
more accessible for
We need
everybody.
some OTs in that space
We
advocating and
do actually.
and brainstorming.
I was part of a group at the Ohio State University where we were doing some work with the local transportation agency that was actually pretty. They were I think their hearts were in the right place, and they were starting to put resources to do that. And we always had our students go down and look at their mobility center and to kind of see the work they were doing. So they would hopefully come out having a good understanding of the role that public transportation plays for so many people, and especially
Yeah.
folks with disabilities. So.
Hmm.
So
That's
I
great.
know from personal experience, my mom once when she was coming home from I can't remember if it was a skilled nursing facility or an inpatient rehab stay. Um, she had, the therapist wrote orders for OT PT. And of course, the PT came and the home health company on their own had changed OT to a nursing assistant twice a week to help with showers. And so, of course, I called and said, we already had a nursing assistant that could help with the showers. We needed the OT to be there. So can you talk a little bit? So hopefully I know something about, um, talking to a home health company to get services for my mom. But can you talk a little bit about why sometimes that happens and maybe what we can do, either an inpatient therapist or as a home health therapist, to ensure that folks get the services that they need?
Yeah, I think it's something that it's almost like a rite of passage. When you become an OT, you're just basically signing up that you're going to be educating people what occupational therapy is for the rest of your life
Sure.
because it's just something that is a big question mark for a lot of people.
Hmm.
And I think it starts on the inpatient side to talk about the role of OT with your patients so that they value your role in their life and not just, oh, I had an OT and she made me make a scrambled egg. I hear that all the time.
Yeah.
And so, but advocating what OT does, start there, and then advocating with your social workers, nursing staff, agencies that you work with, and really also not just saying a patient needs OT, but why they need OT and where our skill level comes in. And that's a huge part of being an OT and giving patients what they need. And then if you work in an agency, it really does, it's our professional responsibility to make sure that we show our value because we can do a lot of great things, especially in home care, but if nobody sees us, they don't really understand what we're doing. So educating your administrators, your care team, all of that. And then some of the things that come into play too are staffing, especially right now. If they don't have an OT, then maybe they, farm it out to something else that they think is going to foot the bill. But a CNA certainly isn't going to do what an OT is going to do.
Hmm.
Sometimes insurance restrictions will come into play, and then sometimes the patient will refuse because they don't value what OT does. People tend to gear more towards, well, I just want to walk, I just want to be
Hmm.
stronger, I'll do PT, I don't need this.
Hmm.
But really to get the language out there and figure out what your elevator speech is for OT so that people are like, oh, I actually really need you.
Hmm.
And we've noticed here that with some of those conversations that we've had with folks, once it clicks and they really get it, it's like they refer to OT all the time because they're
Hmm.
like, well, we at least need OT. Let's get OT in there. And that's a really good thing, but it takes work to keep
Hmm.
OT kind of front and center sometimes.
Sure, absolutely. So we we love our physical therapy friends and our nursing friends,
Hmm.
and our speech language pathology friends. But sometimes they can become gatekeepers. So is
Hmm.
there a language that you might use or you do use to help ensure
Hmm.
that there isn't a gate, or if there is a gate, that the gate is typically swung open so that the patient has access to occupational therapy services?
Yeah. And I think with anything, it really is about the relationship that you have with those individuals and to nurture that relationship, get to know them, let them get to know you. That's really important. And then also provide education that has some, you know, legs to it, so to speak. So if you
Hmm.
have a great article, or I just read a really great article in OT practice about wheelchairs and working with an ATP, I am going to share that with some of the therapists I work with because it really describes the role that we have, and it's a good piece of literature. And so I think just staying on top of things and sharing information. Most of us as therapists, PTs, speech therapists, nurses, we're all kind of we want to learn, we want the information. So we as OTs can just do a good job and give that to them and give them data, give them research. Offer, you can offer to give presentations too.
Hmm.
And we do that with a lot of home care agencies here. We'll come in and talk about our role around low vision or incontinence because it's like, oh, we didn't know you could do all of this stuff.
Hmm.
And that kind of gets that gate to be a little bit less closed. I don't know
Hmm.
if I'm saying that right, but you know what I mean. And then just to be really that bridge to so that other people can walk across the bridge and see what you do and understand what you do and use case studies too. Or if you have a patient that you've done something really awesome with, or even just been successful in any way, share that because those
Hmm.
stories about our patients really go a long way with other
Sure.
professionals.
Yeah, and having having the patient talk to the PT or the nurse
Yeah.
about, the types of things that you're doing, and,
Hmm.
hopefully the difference that that's making.
Yeah.
So I think your business is really interesting, because you're doing this community-based occupational therapy that, I've actually always been fortunate enough to be able to do myself, and have been able to do different types of things, and working really much more when I practice as an occupational therapist as a consultant, and not doing quite as much direct treatment, but it's always in the community. Um, do you feel like that makes a difference in terms of the types of services that you provide, the type of relationship that you have, with the patients you're serving?
I do. There is something that happens, and this happens with home care too, but when you're invited into somebody's home,
Hmm.
it just changes things. There's a little bit more of an intimacy there right out of the gate because you're seeing where they live and, you're going into their bathroom and, their bedroom. You don't even do that with your neighbors. So that changes things for sure with a relationship. It also, I think, gives the patient a little bit more, um, I don't want to say power. That's the wrong word, but it is their house. I mean, they can
Sure.
tell you to leave, whereas if they tell you to leave their room at the hospital, you don't have to leave the whole hospital.
Right.
So, I think that changes some things too. And you can be so client centered that way. And you can really see, a daughter that comes in and out, 5 times during your visit because she lives downstairs.
Hmm.
Or, their cat is all over the place when they're trying to take a shower. You see all this stuff that you can really just create these really beautiful dynamic treatment plans. And that's my favorite thing about being in the home is just, you know, you kind of just get into their life in a real personal level. And it's really beneficial too when you have somebody that has some sort of chronic issue going on. So
Hmm.
let's say, ALS or Parkinson's, a lot of times they need different supportive services at different times. And so when you've already been in there and, then 8 months goes by and they can call you and you can come back and they don't have to explain their whole story again.
Hmm.
It's I love that. And so I have patients that I've seen for years and not consistently, of course, but off and on. And then sometimes until the end of life. And even then, sometimes, we'll treat patients when they're on hospice.
Hmm.
And it just is a really beautiful thing. And, I learn just as much from my patients as they learn from me for sure, just by being part of their lives.
Sure. Nice. Um, so we actually have a number of international occupational therapists and non-occupational therapists, who listen to the podcast. And so,
Cool.
for those OTs, from other countries, in the United States, occupational therapists typically are delivering care within institutions, so hospitals, clinics, schools, skilled nursing facilities, you know, different things, but typically within kind of these four walls. But I think, in my experience, international occupational therapy is a little bit more community based,
Hmm.
and occurs much more frequently, in the community setting. Have you modeled any of your approach on any international models, or have you kind of been able to take advantage of seeing what some folks are doing in other countries?
I have not. I have had actually a couple students that were from out of the country, but
Hmm.
nothing, not a specific model or organization that we've modeled things after.
Hmm.
But I love some of the things that I get to read about other countries and how they're doing things. I think there's so much that we can learn from them.
Sure.
Um, for me with Covell Care here, it's just really been a little bit of an amoeba of what our communities have needed
Yep.
and just sort of responding to the need and not even thinking about it sometimes maybe as I should, like long term, where we'd going with this, but just really like, oh, you have this need, we can help you, no problem,
Right.
and figuring it out from there. So, but yeah, it's I hope that more and more communities will have mobile outpatient services available because it's so good.
Yeah, I was thinking, especially in the United Kingdom and in Canada,
Mhm.
Ireland as well. They have, occupational therapists that, for falls, will ride along on the ambulance, and so,
Mm.
sometimes they'll make a decision not to, if nothing's broken, and that instead of transporting them to the emergency department, I don't know how the occupational therapist gets home, or if they have a
Yeah.
separate car, or how that works, but the OT sort of dropped off and does,
Hmm.
a home evaluation right there, and can make
Wow.
some recommendations in terms of, you just figure how expensive every trip to the emergency department is for our healthcare system, and
Hmm.
also, how stressful it is for the patient to have to go into to go through all the prodding and the poking and possibly a couple nights in the hospital or whatever it might be.
Hmm.
So I think there's a lot of really cool models that are out there that are starting to, there's, I know in some hospitals the occupational therapist or physical therapist is in the emergency department. So, but for some other places, they've kind of taken it one more step, which is kind of
Hmm.
exciting. So that could maybe be your next
I love hearing that.
amoeba move.
Yeah.
Yeah, you could.
I'll be out
It's
in that ambulance tonight. Yeah,
that's right.
but I love
Get a
stuff
little
like
red.
that.
Like the good old days where they had like the light they put on top of the car.
Yeah.
It was like the detective was having to
Yeah.
chase somebody down. You could get the Covell-Care car and just kind of put that on top, and then
I like where you're
you
going with this. Sounds like a good
yeah,
plan.
absolutely. All sorts of things. So,
Hmm.
what's it like when you're? So I know some of the care that you're providing is really in the community.
Hmm.
Are there kind of like if you're doing bus training, those sorts of things? How is that different? Are there any special considerations that you need to think about if you're an occupational therapist interested in following your amoeba model? I guess is
Yeah.
what you call it.
Um, well, from a logistics point of view, you just want to make sure that you have liability insurance and all of that
Hmm.
kind of stuff when you're out and about. But if anything, it just really changes your perspective sometimes when you're working with patients. I had a patient, I've told this story before several times because it just is eye opening. She had had a neck fusion, had decided not to drive, and she spoke English as a second language. Um, and she was very short. So when the transit system came, the stairs, they're really big and tall. And then the way that her house is situated, the bus was sort of lopsided. So for her to get in, she was really having to go up a big hill, and she lost her balance and fell backwards. Luckily, I was behind her. And she got on the bus, and the bus driver was, a really loud guy, a big guy, and talking a million miles a minute. She didn't know what he was saying, and I could tell she was so nervous, and it cost her $3. So she gave him her $3, and we were on our way to the drugstore to pick up a prescription, and he went a different way. And so she became almost into a panic and thought he was kidnapping us. And I thought, oh my gosh, like if I hadn't been here,
Hmm.
she would just be out of her mind. And so I told her, I said, no, 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 we're safe. It's fine. It's fine. But it took her a long time to be willing to do it again. And
Hmm.
so that was part of the therapeutic process. But had I just coached her and not done it with her, I wouldn't have anticipated any of that stuff happening.
Sure.
So that it does really change things. And then, things just happen out in the community that you
Sure.
don't expect. And it really keeps us on our toes as OTs. I was with a OT assistant once, and we had a group of patients we had taken them to Walmart, and one of the women was in her power chair, and she had gotten connected to a clothing rack, and
Oh.
it was going down the Walmart with her. So it's like, oh no. So I'm like, okay, well, add this to the goal list. You can't be doing this. So those are the things you're just like, oh my gosh, like this, I can't believe this is even happening. And then when I brought her attention to it, she said, I didn't do that. So, okay. But yeah, it definitely keeps us on our toes.
Sure, absolutely. So, do you tend to bring tools with you in the community, or when you're doing home health visits, or do you really try to rely on
Mhm.
sort of the natural environment, the things that people have access to?
Both. I usually will just go into my visits not with a whole lot of equipment with me.
Mhm.
And then I do have a couple of different bags of tricks that I keep in the back of my car, that if I need things. So duct tape, puff paint, bump dots, all the OT, stuff that we
Sure.
need, paper, markers, all the things. Um, but no, I don't really bring a lot of stuff. And then we have a really great organization here that we can get adaptive equipment. Sometimes it's used, but pretty cheap.
Hmm.
And so we can take that, and trial things out with patients and stuff, and they're really good about working with us. So that's always nice too. But I keep a few of those things in the car.
Nice. I like to have duct tape on the, like if you use the like paper, like baking paper, you can put duct tape on that,
Hmm.
and then you don't need to have the
Hmm.
whole roll, but you can just pull off what you
Mm.
need.
I didn't know that.
It's my little duct tape trick for you.
All
I've never
right.
done it, but you can probably do like the backside of Velcro once you pull it off. You can probably do that as well.
Right.
So that way,
Hmm.
you don't need to have the whole roll with you all the time. So
That's an awesome idea. Thank you.
I have I have some in my bag with a couple other weird things. Just
I
it's
know.
it's fun to go through TSA sometimes because
Right.
they wonder what you're doing. So
Yes, yes.
there you
I
go.
always said my aunt's an OT, and she always had so much stuff in the back of her car, and I always said I am never going to be like that. Hmm. Oh, famous
When
last words.
I know. Well, I still practice a little bit, but primarily I'm a researcher. But I have
Mhm.
about 5 or 6 giant tubs down in
Yeah.
our basement, and on top of the tubs that I have at my office. And so occasionally my wife is wondering why I still have all those things, and it's been a lifetime of getting those things together. So it's
Hmm.
gonna continue. She has 3 sets of china that she's inherited, so I figure that's always the trade-off that when she
Yes.
gets rid of her china from, I don't know, somewhere that from someone she doesn't know, then I'll get rid of one of my tubs. So, but
There you
so
go.
far I've been able to hold on to the tubs.
Hmm.
Can you talk? I mean, it's like I think your practice is really cool. So some more
Thanks.
examples of some real life examples of people that you've really made a difference in their lives in
Hmm.
terms of the services you're providing.
Yeah, I can. One of my all-time favorite patients. I know we're not supposed to have favorites, but we do. And I met him, and then we saw each other off and on for about 5 years. And he had a progressive neurological disorder, very much kind of a man's man, just very tough, very prideful. He was a physician. He was very well respected in the community. Um, just kind of everything he touched turned to gold all his life. And so he going into this really vulnerable disease was devastating to him in a
Sure.
way that was different than a lot of patients that I work with. And he and I ended up working together. And then he lost a son very tragically, and he was very stoic. But um, eventually, I took him off of billing insurance and all of that stuff. And his wife asked if I would just come sometimes and visit him. And I did. I would bring my dog and sit with him. And he finally one day just had kind of a release about his son and cried and sobbed, and if I hadn't had that relationship with him, I don't know who he would have ever talked to, or gotten to know and stuff. And so it went way beyond OT for us,
Hmm.
became much more of just, kind of that servant position of just wanting to serve
Hmm.
and be there for him. And then off and on, we eventually remodeled his bathroom. We eventually did a lift system. Um, he used to like to go in his backyard, and he had a golf cart. So
Hmm.
I figured out before he got too bad, I figured out how we could get him into the back of the golf cart safely and strap him in there and get him to the
uh,
backyard, which was not pretty, but we could do it.
hmm.
So that was fun. And those were great memories with him. I still talk to his wife, and he's been gone a long time. And then I had another patient. She had ALS, and it was pretty quick in its progression, but her life dream was to go to Alaska on a cruise, and she was just losing skills every few weeks. And she ended up inheriting a little bit of money, and I told her, I said, if you want to go, I'll help you go. And so I researched all these different cruise ships that could accommodate all her equipment. She hired 2 caregivers to go with her, and her oxygen. That was something I didn't realize. Certain airlines won't let you bring different types
Sure.
of oxygen tanks, and the batteries on your power chair have to be a certain type. I didn't know any of that. So, we figured all of that out, and she got home and she got to go, and she actually broke her ankle on the ship
Ooh.
during a transfer. The caregivers were transferring her, and the ship listed one direction. She went the other direction. And so they took her to the little doctor on the ship. And then they said, well, you have to get off at the next port and go to the hospital. And she said, I don't walk and I have ALS. I'm not going anywhere.
Yeah.
So she stayed on the ship with her broken ankle
Uh,
and, had it kind of bandaged up or whatever. But just to be able to help somebody get out there in the world, it means a lot. And,
Hmm.
you never forget those patients either, even after they've passed. Um, and then I just saw a patient recently via telehealth because she lives about 2.5 hours away out of our geographical location. She needs a power chair. She had gotten one from a thrift store and it was just looked like it'd been run over. I mean, it was in bad shape. And ended up working with a wheelchair vendor that could go to her house. I was on telehealth, and then now she's also working with a PT via telehealth, and then eventually we'll work with a personal trainer via telehealth. And she's so excited. She wants to cook and she loves to garden, and she's just doesn't have a lot of services where she lives, and so we've been
Sure.
able to get really creative with that. So those are really that's the most rewarding part of the job, is just to be able to help people live their life the way that they want to.
Yeah, absolutely. I was fortunate enough that I was kind of a not a rec therapist, but did kind of recreational stuff before I
Mhm.
was an OT with people with disabilities. And one of the guys that I came to know pretty well, I ended up working with the person that was kind of in charge of his care.
Mhm.
Was a young man with not young man, a gentleman with CP, and he had a trust fund, and so the push comes to shove, they asked me to kind of be a rec therapist for him
Mhm.
as an occupational therapist. So we had the best time of just really being able to go, and it's kind of my favorite experience as an occupational therapist. But going to football games and basketball
Mhm.
games and going out to dinner and that sort of stuff. And it's really, it's the meaningful occupations of life that really make it
Mhm.
worth living. So it's great when we're able to have the freedom. And I think it seems like some of the choices that you've made kind of give you a little bit more freedom to be able to do
Mhm.
that. So could you talk a little bit about the business aspect of what you're doing? And I know historically occupational therapists have been a little bit reluctant, I think, to bet on themselves and to start their own businesses. But it seems like it's changing a little bit, and there are
Mhm.
more OTs that are kind of really doing that. So, do you have any
Mhm.
tips on someone that might be looking to do Covell care outside of Colorado? I'm
Yeah.
sure that would be something different, but
Mhm.
any tips on someone that's interested in starting their own business and kind of
Mhm.
modeling what they're doing after what you're doing?
Yes, and I always start with personal development,
Mm.
wherever you're at, and figuring out a little bit more about yourself. That's always a good thing because we can be our worst enemy. We can get in our own way, and sometimes our thoughts are what keep us from doing certain things, and
Mhm.
just sort of how to manage those thoughts or insecurities that you might have, or reasons why we don't step out as OTs. It's interesting because even in, the university setting, so many different practitioners, from like chiropractors, physical therapists, there's sort of an expectation that there'll be a small percentage or a percentage of them that
Sure.
will go out on their own. And it's not really expected of the OTs, which is sort of interesting. And so we come out of the gate not thinking that those are options for us. And then, but as we go through things, we're thinking, oh, I would like to do this. And there's nothing out there that looks like that. So then we shy away thinking we can't.
Mhm.
And I think just getting comfortable with following the breadcrumbs of one, if you have a curiosity or you want to know more, call someone like me or find someone in your community, or even if they are a PT or somebody else, that you can talk to about what it looks like for business.
Mhm.
Um, Most communities have a small business development center, which is government funded. And I learned so much from them. And the
Mhm.
courses are affordable, sometimes free. You can
Mhm.
get a business coach, and really helpful because sometimes it's just language too that we don't know profit and loss. We don't know this and that, and just learning those things, learning. So those are a few things. And then also just being open-minded, that if you have a roadblock that comes up, is it really a roadblock, or can you move around it, go over it, whatever it is? And as OTs, we're really good problem solvers.
Mhm.
So that, I think, bodes well for being in business because there's
Right.
always things that come up that we have to, get past. So I would recommend that. And then just trusting yourself
Mhm.
sometimes, and knowing what's in your heart or what you can do, and also know that it's going to be more challenging than you ever thought, but you can do it despite the challenges. And sometimes you just need to hear that you
Hmm.
can do this, you can do this. Um, but yeah, I encourage OTs all day, every day, if they're interested in starting a business, to please lean into that, because
Hmm.
we need OTs out there changing the playing field for our patients.
Yeah, and yeah, obviously there's a lot of Facebook pages and those sorts of things that have
Hmm.
occupational therapists and others that are looking at kind of alternative ways to practice. I was fortunate enough, or not, or silly enough, that I actually started my own company about 9 months into practice,
Oh,
and
wow.
was yeah. So I'd recommend that to everyone. Kind of kidding a little bit. I was
Hmm.
older. I was 27, I believe, so I was, a little more seasoned at that point.
Hmm.
But it's fun even when I talk to former students that are interested. Doing taxes for whatever reason seems to be one of the big hangups that people are
Yeah.
afraid of having to do their quarterlies and doing their own taxes. And I started with a CPA to help with that process.
Hmm.
Lots and lots of deductions when you have your own business is
Hmm.
is nice. But I actually worked with a physician at one point who also was kind of a private contractor, and he was like, I just use TurboTax. And I was like, really? I didn't think. And so I've been doing TurboTax now for the last 10 years or so, and it's
Hmm.
pretty easy, and the IRS has not shut me down yet. So I guess that's a good thing. Um,
Yes.
Now, one of the exciting things is you don't take insurance, correct?
No, we do take insurance.
Okay, Kathleen, can we take that part out? Sorry.
Oh,
See,
that's
I
okay.
relied on Fawn. Just kidding, Fawn. Um, so I'm going to start over with this
Okay.
questions.
Sure.
Kathleen fell asleep. All right. So, what are the pros and cons? I know I'm just teasing Kathleen. Thank you. All right, good. So, what are the pros and cons of accepting insurance?
There's a lot of pros and there's a lot of cons.
Yeah.
We'll start with the cons. The cons is that it's challenging, and it's gotten more challenging in the last several years, mostly thanks to a lot of different types of plans, like your Medicare Advantage plans,
Hmm.
and navigating that. Becoming a Medicare and or Medicaid contractor, depending on what state you're in, is not a difficult process. So I always tell therapists, if they want to take insurance, to start there.
Hmm.
And the good thing, though, is that a lot of the patients, especially that we see with older adults, they have insurance and they want to
Hmm.
use it. And so it opens up the door for lots of patients to come to you and receive services. We have a handful of therapists that come to us with their private practice, and
Hmm.
they are cash pay, but then they have patients that take insurance and they just need somebody to help them with that. And so we
Gotcha.
process their insurance for them. That's no big deal. I would recommend, if you are going to bill insurance, remember that you are a therapist and not a medical biller.
Hmm.
And, a lot of therapists will start out and do their own, which is a great way to learn, but it takes so much time, and you really do want a biller, in my, opinion, that
Hmm.
really is a biller. So let them be the biller and you can be the therapist and the entrepreneur. Um, so I would say the big pro is that you will have probably an easier time getting clients.
Hmm.
And then the big con is that you're going to have an expense to pay for the biller, but they
Hmm.
usually pay for themselves with the collections that you get. And then it just can be complicated and cumbersome sometimes and create a lot of paperwork. So none of us really enjoy that. But
Right.
um, we also see pediatrics, and what we find there is sometimes the insurance plans have such high deductibles and stuff that parents will opt to pay privately instead
Hmm.
of go through their insurance. So there's those options too. So you just have to figure that out, and then also to remember that if you are seeing a patient that has Medicare, as an occupational therapist, we're not allowed to opt out,
Hmm.
meaning that they should be getting their services from an OT that's contracted with Medicare. There are ways around that, but you have to do it legally and with the right paperwork and stuff too. So sometimes I think therapists, just out of being naive, think, oh, I'll just do cash pay for all my older adults. Well, really, professionally, we can't.
Gotcha. So how do you drum up business? Is it, are you cold calling physicians or
Mhm.
skilled nursing, or how do you go about doing that?
Um, well, at different phases of the business, it's been different. So
Hmm.
in the beginning, it's a lot of just beating the streets and going out there, making calls, going to coffee, joining groups, giving presentations, you name it, we did it. Getting to know your community and also just finding things out, asking a lot of questions. It's not always about like, hey, we're Covell-Care, look at us. It's like, hey, who are you and what do you do? Because I might need you for my patients. And that was a lot, and a lot of that. I mean, years of that. Now, it's different because we've been around a while, and so people refer to us pretty consistently, and it's mostly hospitals, physicians, home care agencies, and social workers,
Hmm.
caseworkers from the county. And then sometimes, people find us on the internet and send us an email, but usually somebody in their medical team,
Gotcha.
patient's medical team.
Um,
Mhm.
so what are the risks and rewards for doing your own thing, starting your own business? How has that gone? Seems like you're pretty happy with what you're doing.
I would do it all over again.
Hmm.
So I love what I do. It's a big part of who I am. And, not everybody will feel that way. I feel really lucky to feel that way. The hard part is that when you're the owner, the buck stops with you. So,
Hmm.
if something happens, you're on the line. And when we went through the pandemic and everything was shutting down in
Sure.
2020, that was definitely a really challenging time as a small business owner in healthcare because I didn't have a team of people. I didn't work for a big organization. It was extremely difficult. Um, Very anxiety producing, scary, all the things. Um, if Medicare screws up, like one time they classified all of our claims in as we were cardiologists, so they all got denied. So I'm like, well, thanks a lot. So,
Yeah.
we had nothing to do with that, but that dried up our cash flow for a while. Those things happen. And so it can be very stressful. And then, especially as you've hired employees and other people are depending on you for their livelihood, there's pressure there, so you're responsible for things that maybe you're not in a regular setting. And then in a regular setting too, you don't get to be as creative, so that
Hmm.
there's a huge pro to have your own business with that. And then also you have you so, it's like they say entrepreneurs will work 80 hours a week, so we don't have to work 40 hours a week for somebody else. Um, and it's sort of like that, but you do get to pick and choose what you want to do. And really enjoy that. And then I also love working with the therapists because they're all out there, doing really creative stuff too. And I get to mentor them, and that I love that. So
Hmm.
there's lots of pros and cons.
Gotcha. And so, other than reaching out to you directly, are there things that people that are interested in starting their own business, places that you would recommend they go, websites, organizations that
Mhm.
you think would be useful for them to learn about?
Yeah, I would definitely go if you're going to do Medicare, definitely go to the CMS website, start poking
Sure.
around that, to make you want to go to sleep, but get educated. That, like I said, the Small Business Development Center in your community, I would check out the Better Business Bureau too, or even your local Chamber of Commerce,
Mhm.
and just get to know your community. There are some business coaches out there, and I would recommend getting some sort of mentorship going. One of the mentors that I had, though, I mean, he was a physician that I worked with here in town. It doesn't have to be another OT in business, it can be
Mhm.
somebody else. Um, and get on those Facebook groups, start learning what's going on in the industry, and then just start asking a lot of questions. And then networking groups too. If you have any networking groups in your area or virtually, I would get involved with those.
Mhm.
And then just start, even just go to the library and pick up some books, start learning some different things. We have to remember that even though a lot of people have a master's or a PhD in occupational therapy, we are not business people. So typically, so we have to educate ourselves. And if you feel like you're, not knowledgeable enough, you can learn. And so that's just what it takes is learning. So those are some things I would recommend. And then there's some good webinars out there too, that you can take. But yeah, I just would start chipping away or having some goals of what you want to get done or what you want to learn.
There you go. That was the occupational therapist and you speaking at the end. Get the goal
Right.
directed.
Get your goals in there. Make sure they're measurable.
That's it. Well, Krista, thanks so much. I've really enjoyed our conversation and I appreciate your time today.
Yeah, thank you. And there actually is one other organization too. If you're interested in driving, because we talked about that, is to go to ADED, and that's capital ADED. Can look that up and check that out. We definitely need some OTs in that space. And so that would also be an organization if you're looking for a private business that you would likely do quite well because there's not enough.
Wonderful. Great. Thanks so much. Appreciate it and have a great day.
Thank you.